A case of ventricular pacing in HATTR amyloid cardiomyopathy masking low EKG voltage. Cardiac amyloidosis recognition is increasing thanks to imaging techniques such as cardiac magnetic resonance imaging and scintigraphy. Despite imaging availability, it is still important to recognize early clinical features to identify patients and start prompt treatment. A patient in the 8th decade of life with chronic kidney disease, hypertension, prediabetes, hypothyroidism, paroxysmal atrial fibrillation, and a pacemaker implanted due to sick sinus syndrome developed congestive heart failure, which required a hospitalization due to decompensation. A transthoracic echocardiogram demonstrated a left ventricular EF of 40%, severe left ventricular hypertrophy with a global longitudinal strain of minus 6.9% with apical sparing. Based on these findings, we decided to pursue additional testing to evaluate for amyloid cardiomyopathy. On further interrogation, she referred to our other clinical cues such as polyneuropathy, carpal tunnel syndrome, Schwinger-Figure syndrome, and family history of cardiomyopathy. Additional testing revealed a serum kappa lambda free light chain ratio by immunofixation, negative electrophoresis in serum and urine, and monoclonal proteins. A technetium 99 with pyrophosphate scintigraphy strongly suggested myocardial transthyretin amyloidosis. A TTR genetic pathogenic mutation was detected, and a diagnosis of TTR amyloid cardiomyopathy was made by non-invasive measures. Her medical records revealed an EKG and a TTE performed 5 years prior that showed discordance between the wall thickness by imaging and lack of LVH on the EKG. During the most recent hospitalization, her EKG revealed a change in QRS amplitude while undergoing RV pacing. This patient's treatment was now tailored to manage TTR-CM. Less than 40% of patients with cardiac amyloidosis have low EKG voltage. However, this shouldn't be enough to dissuade clinicians from thinking about amyloidosis. By the time the EKG is characteristic, the disease is advanced. It is important to note that this genetic mutation is associated with 2.5 years of median survival after diagnosis in untreated patients. Cardiac amyloidosis results from unstable misfolded proteins that aggregate and accumulate into insoluble amyloid fibrils. These proteins then deposit in the myocardial extracellular space, blood vessels, bones, and major organs. Pathologic accumulation of this unstable TTR causes heart failure and conduction abnormalities. The accurate incidence of TTR is unknown. The broad symptoms range from neurologic to cardiac involvement, making its diagnosis complex. Discoveries in therapeutics are increasing disease awareness, and cardiac scintigraphy use, along with genetic testing, brings hope to earlier disease diagnosis and treatment. The prevalence of conduction disturbances in amyloidosis has been underestimated since such pathologies are first attributed to other conditions. Implementing cardiac devices with consecutive changes in the voltage pattern can be a potential co-founder if the clinician is unaware of the discordance between an EKG and TTE. Furthermore, it should be seen as a harbinger of a more complex disease, especially if it comes with characteristic red flags for amyloidosis. The typical EKG findings of low voltage complex and pseudoinfarction pattern in the presence of increased left ventricular mass becomes less evident in our patient after implementing the pacemaker, being a potential confounder for low voltage in LVH.